In this video, we are going to discuss about increased intracranial pressure. Before going to the disease condition, let us know what is intracranial pressure. The rigid cranial wall contains brain tissue, blood, and CSF. Intracranial pressure is the result of the amount of brain tissue, blood, and cerebrospinal fluid within the skull at any one time. The volume and pressure of these three components are usually in a state of equilibrium and produce the ICP. We can measure ICP in the ventricle subarachnoid space, subdural space, epidural space, or brain tissue with the pressure transducer. Normal ICP is 5 to 15 mmHg. A sustained pressure greater than 20 mmHg is abnormal. The skull is very hard and is limited on how much it can expand. When something inside the skull experiences a change that leads to increased pressure. To understand the pathophysiology of increased intracranial pressure, you must understand the Monro-Kelly hypothesis. It deals with how intracranial pressure is affected by CSF, brain's blood, and tissue, and how these structures work to maintain cerebral perfusion pressure. The Monro-Kelly doctrine states that the three components must stay at a relatively constant volume within the closed skull. If the volume of any one of the three components increases within the skull and the volume from another component is displaced, the total intracranial volume will not change. This hypothesis is applicable only in situations in which the skull is closed. The hypothesis does not apply in persons with displaced skull fractures or craniectomy, removal of part of the skull. Because brain tissue has limited space to expand, compensation typically is associated with displacing or shifting CSF, increasing the absorption or diminishing the production of CSF, or decreasing cerebral blood volume. Without such changes, ICP begins to rise. Displacement or shunting of CSF from the intracranial compartment to the lumbar subarachnoid space. Normally, about 500 ml of CSF are produced and absorbed in 24 hours. About 125 to 150 ml circulates throughout the ventricular system and the subarachnoid space in the following ratio: 25 ml in the ventricles, 90 ml in the lumbar subarachnoid space, and 35 ml in the cisterns and surrounding subarachnoid space. CSF is absorbed through arachnoid villi back into bloodstream every day. The brain attempts to compensate for rises in ICP by displacement or shunting of CSF from the intracranial compartment to the lumbar subarachnoid space, or increased CSF absorption, or it decreases the production of CSF. The third way, it tries to decrease cerebral blood volume by displacement of cerebrovenous blood into the venous sinuses. But if the pressure is continuous, it is unable to compensate. Increased ICP will ultimately occur if the volume of the intracranial mass exceeds the volume compensated. Cerebral blood flow is the amount of blood in milliliters passing through 100 grams of brain tissue in 1 minute. The global cerebral blood flow is about 50 ml per minute per 100 grams of brain tissue. Maintaining blood flow to the brain is critical because the brain requires a constant supply of oxygen and glucose. The brain uses 20% of the body's oxygen and 25% of its glucose. The cerebral perfusion pressure is the pressure needed to ensure blood flow to the brain. Cerebral perfusion pressure can become compromised during increased intracranial pressure. Therefore, there must be a sufficient cerebral perfusion pressure so that the brain is properly maintained. The normal CPP is 60 to 100 mmHg. When CPP falls too low, the brain is not perfused and brain tissue dies. If the patient's mean arterial pressure starts to fall to the patient's ICP, then the cerebral perfusion pressure will drop. Therefore, maintaining a sufficient mean artery pressure is essential. The lower limit of systemic arterial pressure at which autoregulation is effective is a mean arterial pressure of 70 mmHg. Below this, cerebral blood flow decreases and symptoms of cerebral ischemia such as syncope and blurred vision occur. The upper limit of systemic arterial pressure at which autoregulation is effective is a mean arterial pressure of 150 mmHg. When this pressure is exceeded, the vessels are maximally constricted and further vasoconstriction response is lost. How to calculate CPP? Equation is CPP is equal to mean arterial pressure minus ICP. If BP is 90/42, ICP is 19, first the mean arterial pressure must be calculated. Mean arterial pressure is equal to diastolic BP into 2 plus SBP divided by 3. Diastolic blood pressure is 42. 42 multiplied into 2 is equal to 84. 84 plus 90, that is systolic blood pressure, is equal to 174. 174 divided by 3 is equal to 58. So 58 is the mean arterial pressure. 58 minus 19 is equal to CPP, that is 39, is very low. So normal CPP is 60 to 100 mmHg. In short, this hypothesis says that if the volume of one of these structures increases, the others must decrease their volume to help alleviate pressure. When there is an increase in intracranial pressure, the body can temporarily compensate for it by shifting CSF to other areas of the brain or spinal cord, or decrease its production and alter blood volume going to the brain through vasoconstriction. But if the pressure is continuous, it is unable to compensate, so it leads to increased intracranial pressure. Intracranial pressure fluctuates, and this can depend on many factors like person's body temperature, oxygenation status, especially carbon dioxide and oxygen levels, body position, arterial and venous pressure, anything that increase intra-abdominal or thoracic pressure like vomiting, bearing down, etc. For the brain to receive proper nutrients to work, it must receive a certain amount of cerebral blood flow. This is the amount of blood flow into the brain's tissue. It does this by altering the cerebral perfusion pressure via vasoconstriction or vasodilation. For example, if carbon dioxide levels are abnormally high, more than 45, vasodilation occurs, which allows more blood volume to enter the brain. However, this is not good if a patient has increased ICP, because this will further increase the intracranial pressure. Next, we will see the causes of an increased pressure within the skull that leads to increased intracranial pressure. They are injury or head trauma, increased in cerebrospinal fluid, hemorrhagic stroke or aneurysm burst, hematoma, subdural or epidural hematoma, bleeding in between structures in the brain, hydrocephalus, buildup of CSF in the brain normally flows through the brain and the spinal cord and enters the bloodstream. It may be blocked or too much is produced. Patient with a tumor putting pressure on brain, encephalitis, inflammation of brain tissue, or meningitis, inflammation of membrane covering spinal cord and brain. Now let us see the pathophysiology. At a certain point, the brain's ability to autoregulate becomes ineffective and decompensation begins. Due to any injury or insult to the brain, there can be pressure building up in the brain. Because of the pressure, the brain is getting squeezed. It compresses the ventricles and blood vessels that leads to decreased cerebral perfusion, and it limits cerebral blood flow to the brain and that leads to ischemia with decreased oxygen and death of brain cells. All of these can lead to swelling and edema, which will eventually, if not treated, lead to herniation or displacement of the brain. The displacement of the brain can compress important area of the brain like the brainstem. Increased ICP with compression of brainstem and the respiratory center cause accumulation of carbon dioxide. To remove excess carbon dioxide, body try to dilate the blood vessels. Vasodilation causes more increased ICP resulting from increased blood volume. Finally, the patient may die due to increased ICP. When CPP falls too low, the body tries to increase systolic blood pressure to make more blood go to the brain. But this makes things worse. During this time, the arteries will start to dilate because of the retention of carbon dioxide. This causes more blood to flow to the brain, but this will compress veins and limit blood flow to the heart, hence leading to more swelling and even more ICP. As all this progresses, the patient's signs and symptoms will start to become worse. Therefore, it is essential to know the earliest signs and symptoms of increased ICP, that is, mental status changes. Although elevated ICP is most commonly associated with head injury, an elevated pressure may be seen secondary to brain tumors, subarachnoid hemorrhage, and toxic and viral encephalopathies. Increased ICP from any cause decreases cerebral perfusion, stimulates further swelling, and may shift brain tissue, resulting in herniation, a tear, and frequently fatal event. Now we will see the signs and symptoms of increased ICP. If ICP increases to the point at which the brain's ability to adjust has reached its limits, neural function is impaired. This may be manifested at first by clinical changes in level of consciousness. The earliest sign of increasing ICP is a change in LOC, agitation, slowing of speech, and delay in response to verbal suggestions may be early indicators. Any sudden change in the patient's condition, such as restlessness without apparent cause, confusion, or increasing drowsiness, has neurologic significance. These signs may result from compression of the brain due to swelling from hemorrhage or edema, an expanding intracranial lesion, hematoma or tumor, or a combination of both. As ICP increases, the patient becomes stuporous, reacting only to loud or painful stimuli. At this stage, serious impairment of brain circulation is probably taking place and immediate intervention is required. As neurologic function deteriorates further, the patient becomes comatose and exhibits abnormal motor responses in the form of decortication, that is, an abnormal flexion of the upper extremities and extension of the lower extremities, decerebration, extreme extension of the upper and lower extremities, or flaccidity. If the coma is profound and irreversible with non-confounding factors, brainstem reflexes are absent and respirations are impaired or absent, the patient may be evaluated for brain death. We have to assess the change in level of consciousness which is caused by increased ICP. Patient may be drowsy, lethargic. Early behavioral changes such as restlessness, irritability, confusion, and apathy may be seen in the patient. Falling score on the Glasgow Coma Scale. Change in orientation, disorientation to time, place, or person. The patient may have difficulty or inability to follow commands, difficulty or inability in verbalization or in responsiveness to auditory stimuli. Change in response to painful stimuli, posturing. The patient may have abnormal flexion or extension. Next, we have to assess for the changes in vital signs caused by pressure on brainstem. Rising BP or widening pulse pressure. Widening pulse pressure is the difference between systolic and diastolic BP. This may be followed by hypotension and label vital signs indicating for the brainstem compromise. Pulse changes with bradycardia changing to tachycardia as ICP increases. Patient may have respiratory irregularities such as tachypnea, slowing of rate with lengthening periods of apnea, chain stocks or kusumal breathing, central neurogenic hyperventilation that is prolonged deep breathing, apneistic breathing and ataxic breathing. Chain stocks breathing is the rhythmic pattern of increasing and decreasing depth of respirations with periods of apnea. Kusumal breathing, also known as Kusumal respirations, is an abnormal breathing pattern characterized by rapid, deep breathing at a consistent pace. It is a form of hyperventilation. Apneistic breathing is a type of abnormal breathing pattern characterized by deep gasping inspiration with a pause at full inspiration followed by a brief insufficient relief. It is caused by damage to the upper part of the pons. Ataxic breathing is a pattern of breathing characterized by irregular respirations with abnormal pauses and periods of apnea, and this is caused by damage to the medulla oblongata. Patient may have hyperthermia followed by hypothermia. We have to watch for Cushing's triad. Cushing's triad is a term used to describe three symptoms that happen together and usually signal increased intracranial pressure that require immediate care. These symptoms include irregular breathing pattern, an increasing gap between systolic and diastolic blood pressures, widening pulse pressure, hypertension, a drop in your heart rate, bradycardia. This is a classic symptomatology related to uncompensated increased ICP and is considered a neurologic medical emergency. Alert healthcare provider and prepare for therapeutic intervention. Respiratory irregularities may not be apparent if the patient is mechanically ventilated. We have to assess nerve changes to optic and oculomotor nerve. Patient may experience double vision, papillary edema from optic nerve compression. Pupil changes may be seen, decreased, increased or unequal size. Abnormal dots eyes. Assess for oculocephalic reflex. In an unconscious patient, open the eyes and move the head from side to side. If eyes don't move in the opposite direction but stay fixed in a midline position, this is very bad sign. It indicates brainstem damage. We have to assess for other changes such as headache, increasing in intensity and aggravated by movement and straining, vomiting, recurrent with little or no nausea, especially in early morning, may be projectile, papillary edema from optic nerve compression, subtle changes such as restlessness, headache, forced breathing, purposeless movements, and mental cloudiness, motor and sensory dysfunctions such as proximal muscle weakness and presence of pronator drift, contralateral hemiparesis progressing to complete hemiplegia, speech impairment such as expressive, receptive, or global aphasia when dominant hemisphere involved, seizure activity, focal or generalized seizure activity, decreased brainstem function to be assessed such as loss of corneal reflex, gag reflex, and ability to swallow. Pathologic reflexes to be assessed, that is Babinski, grasp, chewing, and sucking reflexes. Let us see diagnostic test. Lumbar puncture to check CSF protein, WBC, and glucose. It should not be done if there is a risk of herniation. Laboratory studies including CBC, coagulation protein, electrolytes, serum creatinine, ABGs, ammonia level, drug and toxicology screen to be done. CT scan and MRI scan are the most common diagnosis tests. ICP monitoring provides useful information. Ventriculostomy, subarachnoid bolt or screw, epidural monitor, fiber optic monitor. By these, we can monitor intracranial pressure. Now, let us see the medical management. Increased ICP is a true emergency and must be treated promptly. Immediate management involves invasive monitoring of ICP, decreasing cerebral edema, lowering the volume of CSF, or decreasing cerebral blood volume while maintaining cerebral perfusion. Drug therapy. Drug therapy plays an important part in the management of increased ICP. First one is mannitol. Mannitol is an osmotic diuretic given IV. Mannitol decreases ICP in two ways: plasma expansion and osmotic effect. The immediate plasma expanding effect reduces the hematocrit and blood viscosity. This increases cerebral blood flow and cerebral oxygen delivery. A vascular osmotic gradient is created by mannitol. Thus, fluid moves from the tissues into the blood vessels, reducing the ICP because of the decrease in the total brain fluid content. Monitor fluid and electrolyte status when osmotic diuretics are used. Mannitol may be contraindicated if renal disease is present and serum osmolality increased. Next is hypertonic saline solution is another option. It produces massive movement of water out of edematous, swollen brain cells and into blood vessels. This movement can reduce swelling and improve cerebral blood flow. Care during an infusion includes frequent monitoring of BP and serum sodium levels because intravascular fluid volume excess can occur. Hypertonic saline infusion is just as effective as mannitol when treating an increased ICP. They are often used concurrently when caring for a patient with a severe brain injury. Next drug is corticosteroids. Corticosteroids such as dexamethasone are used to treat vasogenic edema around tumors and abscesses. These drugs are not recommended for traumatic brain injury. It stabilizes the cell membrane and inhibits the synthesis of prostaglandin, preventing the formation of pro-inflammatory mediators. It also improves neuronal function by improving cerebral blood flow and restoring autoregulation. Complications associated with the use of corticosteroids include hyperglycemia, increased incidence of infections, and GI bleeding. Regularly monitor fluid intake and sodium levels. Perform blood glucose monitoring at least every 6 hours. Patients receiving corticosteroids should receive antacid, histamine, H2 receptor blockers, that is cimetidine, ranitidine, or proton pump inhibitors, that is pantoprazole, to prevent GI ulcers and bleeding because it is a complication of corticosteroids. IV 0.9% sodium chloride is a preferred solution for giving secondary medications. If 5% dextrose in water or 0.45% sodium chloride is used, serum osmolarity decreases and an increase in cerebral edema may occur. Metabolic demands such as fever greater than 100.4 degree Fahrenheit, agitation or shivering, pain and seizures can increase ICP. Implement measures to reduce these metabolic demands to lower the ICP in the at-risk patient. Monitor patients for seizure activity. They may need prophylactic anti-seizure medication, phenytoin, that is dilantin. Maintain the temperature at 96.8 to 98.6 Fahrenheit by using antipyretics, that is acetaminophen, cool baths, cooling blankets, ice bags, or intravascular cooling devices as needed. Avoid letting the patient shiver or shake since this increases the metabolic workload on the brain. If this occurs, the patient may need sedatives or a different cooling method. Drug therapy for reducing cerebral metabolism may be an effective way to control ICP. Reducing the metabolic rate decreases the cerebral blood flow and therefore ICP. High doses of barbiturate, that is pentobarbital, thiopentol, are used in patients with increased ICP refractory to other treatments. Barbiturate decreases cerebral metabolism, causing a decrease in ICP and a reduction in cerebral edema. With this treatment, monitor the patient's ICP, blood flow, and EEG. Barbiturate dosing is typically based on analysis of the beside EEG tracing and the ICP. The healthcare provider orders the barbiturate infusion at a rate that achieves a desired level of brainwave suppression to control ICP. Total burst suppression, recognized by the absence of spikes showing brain activity on the EEG monitor, shows that maximal therapeutic effect has been achieved. If patient does not respond to conventional treatment, cellular metabolic demands may be reduced by administering high doses of barbiturate or administering pharmacologic paralyzing agents such as pancuronium or pavolone. Now let us see the nursing interventions. Establish and maintain airway, breathing and circulation ABC to be maintained. Promote normal partial pressure of carbon dioxide. Hyperventilation is not recommended for prophylactic treatment of increased ICP as cerebral circulation is reduced by 50% the first 24 hours after injury. Hyperventilation causes cerebral vasoconstriction and decreases cerebral blood flow to decrease ICP. This can potentiate secondary injury to the brain. Hyperventilation should be used only after all other treatments options have been exhausted or in an acute crisis. Avoid hypoxia. Decreased partial pressure of oxygen less than 60 mmHg causes cerebral vasodilation, thus increasing ICP. Maintain cerebral perfusion pressure greater than 50 mmHg. Normal CPP is 60 to 100 mmHg. Administer mannitol and osmotic diuretic if ordered to reduce the edema. Administer hypertonic saline if ordered. It creates an osmotic gradient that pulls extra fluid from the brain with an intact blood-brain barrier. Lowers ICP, improves cerebral blood flow by reducing viscosity and improves oxygen carrying capacity. Saline 23.4% is used as bolus to treat acute increases in ICP in conjunction with or in place of mannitol. Requires central access for administration and should be given over 5 minutes. Insert an intuitive urinary catheter for management of diuresis. Administer corticosteroids such as dexamethasone as ordered to reduce vasogenic edema associated with brain tumors. Corticosteroids are not recommended in the treatment of cytotoxic or intracellular cerebral edema related to trauma or stroke. Monitor effects of anesthetic agents such as propofol and sedatives, for example, midazolam and dexmedetomidine hydrochloride, which may be given to prevent sudden changes in ICP due to coughing, straining, or fighting the ventilator. Short-acting medications are preferred to allow for intermittent neurological assessment. Maintain balanced fluids and electrolytes. Watch for increased or decreased serum sodium due to the following conditions that may occur with increased ICP. Diabetes insipidus results from the absence of antidiuretic hormone ADH. This is reflected by increased urine output with elevation of serum osmolarity and sodium. The syndrome of inappropriate antidiuretic hormone results from the secretion of antidiuretic hormone in the absence of changes in serum osmolality. This is a hypervolemic state reflected by decreased urine output with decreased serum sodium and increased free water. Several salt wasting is associated with abnormal release of aldosterone, resulting in increased elimination of sodium and decreased interstitial oleum, that is hypovolemic state. High-dose barbiturate such as pentobarbital may be used in patients with refractory increased ICP. Prophylactic use is not recommended. It is utilized when all other treatments have failed. Dosing is 10 mg per kg over 30 minutes, then 5 mg per kg every hour for 3 hours, followed by maintenance dose of 1 mg per kg per hour. Goal is to maintain serum barbiturate level of 3 to 4 mg per dl. High dose barbiturate induce a comatose state and suppress brain metabolism, which in turn reduces cerebral blood flow and ICP. Only pupillary response is assessed. Be alert to the high level of nasal support required. All responses to environmental and noxious stimuli, suctioning, turning are abolished, as well as all protective reflexes. Cough or gag reflex will be absent and the patient will be unable to protect the airway, increasing susceptibility to pneumonia. Monitor ICP, arterial pressure, and serum barbiturate levels as indicated. Perform continuous EEG monitoring to document burst suppression of cortical activity, and ensure adequate dosing of barbiturate if used. Monitor temperature because barbiturate cause hypothermia. Monitor for diminished GI motility and high risk for ileus. Maintain normothermia and treat fever aggressively. Fever increases cerebral blood flow and cerebral blood volume. Acute increases in ICP occur with fever spikes. Cerebral temperature is 4 to 5 degrees higher than body core temperature. Therefore, small increases in body core temperature can create drastic increases in the core temperature of the brain. Infection is a common complication of ICP, and in the presence of fever, an infectious workup should be completed. Avoid positions or activities that may increase ICP. Keep head in alignment with the shoulders. Neck flexion or rotation increases ICP by impeding venous return. Keep head of bed elevated 30 degrees to reduce jugular venous pressure and decrease ICP. Minimize suctioning. Keep procedure less than 15 seconds and, if ordered, instill lidocaine via endotracheal tube before suctioning. Coughing and suctioning are associated with increased intrathoracic pressure, which is associated with ICP spikes. Inject 5 to 10 ml of lidocaine into ET tube before suctioning to dampen the cough response. Minimize other stimuli such as alarms, television, radio, and bedside conversations, which may increase ICP. Stimuli that create elevation in ICP are patient dependent. That means it depends on each patient. Maintain normal blood sugar levels. Treat with sliding scale insulin or insulin drip as ordered. Initiate treatment modalities as ordered for increased ICP above 20 mmHg or if there is a significant shift in pressure. Pre-treat prior to non-activities that raise ICP and avoid taking pressure readings immediately after a procedure. Allow patient to rest for approximately 5 minutes. Record ICP readings every hour and correlate with the significant clinical events or treatment, suctioning, turning, etc.